So this is a review of oral medicine in the chapter of salivary gland pathology. The first, this is chapter 11 of the oral and maxillofacial pathology book. The salivary gland aplasia is a rare developmental anomaly that can affect one or more of the major salivary glands. One or more of the major salivary glands. So remember, aplasia is a failure of an organ or tissue to develop or function normally. So a salivary gland aplasia is a rare developmental anomaly that can affect one or more of the major salivary glands. The condition may occur alone, although agenesis of the glands is often a component of one or more of more or of one of several syndromes, including mandibulofacial dysostosis, as in Treacher-Collins syndrome, hemifacial microsomia, lacrimal auriculodental digital syndrome, LADD, lacrimal auriculodental digital syndrome. Um, so what is going to be the clinical and radiographic features? Salivary gland aplasia has been reported more frequently in males and females with a 2-to-1 ratio. Some individual, um, some individuals are affected by agenase. ¿Qué necesitas? ¿No estás buscando algo? Pero pensé que me querías. Sí, se está lavando. um, Salivary gland aplasia has been reported more frequently in males and females by a 2-to-1 ratio. Some individuals are affected by agenesis, agenesis of all four of the largest glands, both parotids and submandibular glands. But others may be missing only one to three or four glands. In spite of absence of the glands, the face still has a normal appearance because the sites are filled by fat or connective tissue. Intraorally, the orifices of the missing glands are absent. Some patients also may exhibit absence of lacrimal glands or lacrimal puncta. As would be anticipated, the most significant symptoms associated with salivary gland aplasia is severe xerostomia with its attendant problems. The tongue may appear leathery, and the patient is at greater risk for developing caries and erosion. However, some degree of moisture still may be present because of the continued activity of the minor salivary glands. Absence of the major glands can be confirmed by um, computer tomography, by magnetic resonance, and ultrasonography. So the LADD syndrome we were talking about earlier, which is the lacrimal auricular dental and digital syndrome, is a syndrome that is autosomal dominant and is caused by mutations. Characterized by aplasia or hypoplasia of the lacrimal or salivary glands, cup-shaped ears, hearing loss, and dental and digital anomalies. Dental features may include hypodontia, microdontia, mild enamel hypoplasia. Treatment and prognosis. Patient management is directly directed toward compensating for salivary gland deficiency. Saliva substitutes are often necessary if any residual function of salivary gland tissue is present. Then sialogogue medications such as prilocaine or cevimeline may be used to increase salivary production. Saliva flow also may be stimulated via the use of sugarless gum or sour candy. Regular preventive dental care is important to avoid xerostomy-related caries and enamel breakdown. A mucocele is a common lesion of the oral mucosa that results from rupture of the salivary gland duct and spillage of mucin into the surrounding soft tissues. This spillage is often the result of local trauma, although there is no known history of trauma in many cases. Unlike the salivary duct cysts, a mucocele is not a true cyst because it lacks epithelial lining. Some authors, however, have included true salivary duct cysts in the reported series of mucoceles, sometimes under the classification of retention mucocele or mucus retention cyst. Because of these two entities exhibit distinctly different clinical and histopathological features, they are discussed separately later. So mucoceles typically appear as a dome-shaped mucosal swellings that can range from 1 to 2 millimeters. So key, mucoceles typically appear as dome-shaped mucosal swellings, okay? 1 to 2 millimeters to several centimeters in size. The most common in children and young adults, perhaps because they are more common because they are more likely to experience trauma that induces mucin spillage. However, mucoceles have been reported in patients of all ages. The mucin below the mucosal surface often turns or imparts a bluish translucent hue to the swelling, although deeper mucoceles may be in normal color. The lesion characteristically is fluctuant, but some mucoceles may feel firm to palpation. The reported duration of the lesion can vary from a few days to several years. Most patients report that the lesion has been present for several weeks. Many patients relate the history of recurrent swelling that periodically may rupture and release its fluid contents. The picture in the book is a blue pigmented nodule on the lower lip. A mucocele is the next picture in which you see a nodule on the posterior buccal mucosa. Then the next is a mucocele, which is an exophytic lesion of the anterior ventral tongue. In So a mucocele, it results from a rupture of a salivary gland duct with spillage of mucin into the connective tissue. Children and young adults, any person can get them. Okay. Most common location is the lower lip, buccal mucosa, ventral tongue, floor of the mouth. They can occur in these other areas because they have salivary glands here. Mucoceles are squishy upon digital palpation, but they can be firm as well. A mucocele can also be exophytic. It can be also an exophytic lesion on the anterior ventral tongue that the picture shows. Histopathologic features are spilled mucin surrounded by granulation tissue. And this is because the duct has been severed. Ruptured salivary gland duct may be evident. Adjacent salivary glands often contain a chronic inflammation reaction. Remember, mucoceles are not lined by epithelium, they are lined by granulation tissue. This is very important. Mucoceles are not cysts because they are not lined by epithelium, but they are lined by granulation tissue. A mucocele is a can be also a vesicle line lesion on the palate, or it can be an exophytic lesion in the anterior ventral tongue. It can be a nodule on the posterior buccal mucosa. So nodules, uh, vesicles, and exophytic lesions. The treatment and prognosis. This mucocele may rupture and heal spontaneously. Local surgical excision can be done, but must also remove the adjacent minor salivary gland. Adjacent minor glands should be removed. Prognosis is excellent, but may recur. Now, a ranula is the next. A ranula is a term used for mucoceles that occur in the floor of the mouth arising from sublingual glands. The name is derived from rana, which means frog, because they resemble the translucency of the underbelly of a frog. Um, it is usually due to spillage of mucin from the sublingual gland. They're located lateral to the midline, which is a good way to distinguish a ranula from the midline, a ranula from a midline dermoid cyst. Okay. Um, so there's different types of ranulas, which could be a plunging, or I mean, let's see. Ranulas more often seen in children or young adults. They tend to be larger than mucoceles. Located lateral to the midline, a feature that helps distinguish between a uh, a midline dermoid cyst. Okay, so an unusual variant, a plunging or cervical ranula, occurs when the spill mucin dissects through the mylohyoid muscle and produces swelling within the neck. Okay, we're not gonna worry about that. So next, salivary duct cysts. Salivary duct cysts. Again, well, let's go back to ranula. Ranula is histopathologically similar to mucocele. Spilled mucin elicits granulation tissue response. A ranula, you can tell the difference between a ranula and a silolith by a radiograph. Treatment and prognosis: removal of the feeding sublingual gland and or marsupialization. Again, removal of the feeding sublingual gland and or marsupialization. Remove the roof of the intraoral lesion, which often can be successful for small superficial ranulas. Removing the offending gland is the most important consideration in preventing recurrence. Granules can cause the tongue to push up. Okay, so now salivary duct cysts. Salivary duct cysts um, salivary duct cysts are true cysts that are lined by epithelium. And this is the difference between a mucocele and a ranula, in which they are lined by granulation tissue. These salivary duct cysts are separate from the adjacent normal salivary ducts. Lesions in bone that are not true cysts. Okay, it's best if I just go ahead and read salivary duct cysts. The salivary duct cysts are also named mucus retention cysts, mucus duct cysts, or sialocysts. The salivary duct cyst is a epithelium-lined cavity that arises from salivary gland tissue. Unlike the most common mucocele, it is a true developmental cyst that is lined by epithelium that is separated from the adjacent normal salivary glands. The cause of such cyst is uncertain. Cyst-like dilation of salivary glands also may develop secondary to ductal obstruction, like a mucus plug, which creates increased intraluminal pressure, although some authors refer to such lesions as mucus retention cysts. Such lesions probably represent salivary duct ectasia rather than a true cyst. So salivary duct cysts usually occur in adults, and can rise within either the major or minor salivary glands. Cysts of the major salivary glands are most common within the parotid gland, presenting as slow-growing asymptomatic swellings. Intraoral cysts can occur at a minor gland site, but most frequently they develop in the oral, in the floor of the mouth, buccal mucosa, and lips. They often look like mucoceles and are characterized by soft fluctuant swelling that may appear bluish depending on the depth of the cyst below the surface. Some cysts may feel relatively firm to palpation. Cysts in the floor of the mouth often arise adjacent to submandibular duct and sometimes have an amber color. On rare occasions, patients have been observed to develop prominent ectasia of the excretory ducts of many of the minor salivary glands throughout the mouth. Such lesions have been termed mucus retention cysts, although they probably represent multifocal ductal dilations. The individual lesions often present as painful nodules and demonstrate dilated ductal orifices of the mucosal surface. Mucus or pus may be expressed from these dilated ducts. Isolated salivary duct cysts are treated by conservative surgical excision. For cysts in the major glands, partial or total removal of the gland may be necessary. The lesion should not recur when this is done. So let's go back and see the treatment and prognosis of the ranulas and the mucoceles. In the ranulas, um, is the removal of the gland or marsupialization as well. Next is sialylates. And just review that salivary duct cysts. Remember that ranulas and mucoceles, we're not going to have epithelium in the cyst. That's why they're not cysts, they're pseudocysts. In these salivary duct cysts, we will find a cuboidal, maybe columnar or atrophic squamous epithelium. And so the lining epithelium of a salivary duct cyst may um, undergo oncocytic metaplasia. Oncocytic metaplasia is oncocytic change is defined as a cellular enlargement characterized by an abundant eosinophilic granular cytoplasm as a result of accumulation of altered mitochondria. Okay. Uh, So treatment and prognosis, conservative surgical excision. You may need to remove it because the mucus will go back up into the gland and cause inflammation, which leads to the gland dying. So major gland lesions, partial or total removal of the gland, the recurrence is rare. Sialoliths. Sialoliths are calcified structures within the ductal system. How they occur, they arise from the deposition of calcium salts around a natus of debris, which is a collection. It can be a collection of bacteria lodged into a duct. Um, it can be mucus, bacteria, epithelial. There's a central spark initiate stone formation that can be mucus, bacteria, epithelial, something, or foreign body. Cause is unknown, but it can be promoted to form from chronic salivary gland inflammation and particular obstruction. They do not develop due to any systemic problem. in calcium or phosphorus. Most common locations are mandibular gland because the duct is long and tortuous and the secretions are thicker and more mucoid in consistency. May look like a ranula, so palpate to check if it's firm. If it's firm, it's a cyalyte. You can also take occlusal radiographs and they will show. Cyalytes on the buccal mucosa overlying sentence duct is an image that you can see in the book. And these cyalytes can block the parotid gland. So a cyalolid looks like in an X-ray image, you will see a soft tissue radiograph with the same lesion revealed laminated calcified mass. Cyalolids are also seen in the glands of the upper lip or buccal mucosa. Young and middle-aged adults are typically the ones who have it, but it can occur at any age, asymptomatic or associated with pain or swelling at the mealtime because the salivary glands are being stimulated. So in X-rays, you will see a radiopaque mass that will show you the cyalyte. The appearance will vary on the radiograph depending on how much calcification has occurred. May appear along the length of the duct or within the gland itself. Other pathologies that may show calcifications below the inferior border of the neck can be fibrilate of a vessel, and okay, that's enough. If occurring in the parotid gland, it can look like multiple parotid lymph nodes, which is what occurs in tuberculosis. So that could be, if you don't have an X-ray, that could also be a differential of tuberculosis. Differential. So, okay, so um, Sialolithiasis, histopathologic features, concentric laminations around uh, a central nidus of amorphous debris, which is onion-like concentric laminations. Duct metaplasia or sialadenitis. If you remove the duct, the metaplasia or sialadenitis is often present. Ductal metaplasia means that the epithelium is transitioning from cuboidal to squamous. Ductal metaplasia. So, um, sialulids are calcified structures, most often developed in the ductal system of the submandibular gland, accounts for 80% of the cases. The formation of stones within the parotid gland system is distinctly less frequent. The long, um, we already saw that. Okay, next is xerostomia. We're going to review xerostomia. Actually, we didn't review yeah, we did see sialolithiasis. But xerostomia, let's review xerostomia. Xerostomia. Okay, so refers to subjective sensation of dry mouth. It is frequently, but not always, associated with salivary gland hypofunction. I have to clean my glasses. So there's different factors that are associated with xerostomia. And there's a table, there's a box, box 101, I mean 11.1, that is describes all of this. 25% are older adults. And they are often the result of other factors, not age. More than 500 drugs may produce xerostomia as a side effect, only including 63% of the 200 most frequently prescribed in the United States. So it can be developmental origin, which is salivary gland aplasia, water or metabolite loss, impaired fluid intake, hemorrhage, vomiting, or diarrhea, iatrogenic origin, which can be medication, radiation therapy of the head and neck, or chemotherapy, systemic diseases like Sjogren's syndrome, diabetes, uh, 1 and 2, sarcoidosis, amyloidosis, HIV, hepatitis, uh, graft versus host disease, or psychogenic disorders. Local factors, they decreased mastication, smoking, or mouth breathing. Medications that may induce xerostomia, Antihistamine drugs. Antihistamine drugs, like diphenhydramine, chlorphen, chlorpheniramine, decongestants like pseudoephedrine, loratadine, antidepressants like citalopram, fluoxetine, paroxetine, sertraline, bupropion, amitriptyline, antipsychotics like haloperidol, well, etc. Sedatives like diazepam, lorazepam, alprazolam, antihypertensives like reserpine, methyldopa, chlorothiazide, furosemide, metoprolol, calcium channel blockers, and anticholinergics like atropine and scopolamine. Clinical features: patient demonstrates reduction of salivary secretions, and the residual salivary appears either foamy or thick or ropey. Now we're going to stop here. We've been recording for 38 minutes. Let's start a new video.